Dr. Deepak Khandelwal is going to take this session. And Dr. Deepak Khandelwal is a well-renowned endocrinologist practicing in the western part of Delhi at Paschim Vihar at his own clinic, and he's attached to multiple hospitals. Uh, Dr. Deepak is a very dear friend, and he has innumerable number of publications to his account, and he's an excellent speaker. He's being sought after as a speaker in multiple national and international conferences. So let's start with this session, and then please go ahead and write your question and answers in Q&A box, which we would be taking at end of this session. So let's start with this session.
Sincere thanks to Dr. Rajiv Singla for conceptualizing this program and making me part of this program. Thank you, SPRI team. Thank you, IAP team, for collaboration on this very important topic for a very important cause. And thank you giving me this opportunity. Thank you everyone for joining for today's meeting. This again, thanks to Dr. Rajiv Singla for providing me these slides. And I think he has really done a lot of hard work, in getting the older studies, getting these slides, and making this program very conceptual. So these all slides, they've been provided by Dr. Rajiv Singla only. So this is a very old article, and I think we all know insulin was discovered in the year 1922. 2 years back, we have already completed 100 years of insulin discovery. In fact, in 2022, SPRI as a society did one online program in the celebration of 100 years of insulin discovery. So, of course, things have become much better in the last 100 years as far as insulin treatment is considered. However, on the other way, we have to still go a very long way. In spite of whatever has been done in the last 100 years, the ideal glycemic control is still like a dream for children with type 1 diabetes, their families, and for the treating physicians, pediatricians, or endocrinologists. So, of course, we have so many insulins in the last so many years. We have newer insulins, analog insulins, newer technologies coming up, pumps, but still the ideal glycemic control is a dream. This is again 4 years after the insulin discovery, a very landmark statement in 1926 by Dr. Lawrence. The attempt to keep the blood sugar constantly normal may be ideal in theory, but in practice, it is very difficult to achieve and makes the diabetic life unnecessarily hard without adequate benefit. So, that point of time, the benefits of intensive glycemic control, the evidence was not available. However, now we have a clear evidence that intensive glycemic control can decrease the risk of long-term micro and macrovascular complications. On the contrary, still achieving ideal glycemic control is, it may be ideal in theory, but again in practice it is very, very difficult, again especially for children with type 1 diabetes. So when we talk about complications of diabetes, we can broadly divide into microvascular complications, macrovascular complications, and associated complications. So in microvascular complications, we have primarily three complications: neuropathy, retinopathy, and nephropathy. In macrovascular complications, again, we have three complications: cardiovascular disease, stroke, and peripheral arterial disease. Then we can have associated complications, which can involve like infections. Infections can be again non-specific infections like skin infections, or they can be diabetes specific infections like emphysematous pyelonephritis or rhinocerebral mucormycosis. Other complications, they can be like dental complications like dental caries, musculoskeletal complications of diabetes, and skin changes in diabetes. Each of these topic can have further 1 hour discussion. So I will be just basically talking about the overview. What is important? Once these complications set in, the treatment is more challenging. It is almost impossible to reverse the complications. Once something has happened, you can further prevent it, to progress, regressing. Like somebody has already developed neuropathy and now making it is like a normal. No, it can happen in the early stage, but it's quite rare. So you cannot regress or reverse complications. This can happen, but this is rare. You can prevent the further progression of complications. So what is actually important, that you have to prevent these complications. And one of the strategies is screening for complications, because whether it is retinopathy or nephropathy, the symptoms will come in the late stage of the disease, when the complications is already advanced. So if you want to detect early and if you want to intervene early, you have to screen for these complications proactively. So for most of these complications, the annual screening, once in a year screening, is like mandatory, at least by, I will discuss that part. So again, you can see this is again a very old article, 1978. And again, all credit goes to Dr. Rajiv Singla for going into so much of literature and, digging out these old articles. So you can see here, prognosis of diabetics with diabetes onset before the age of 31. So, they are talking about juvenile diabetes at that point of time. And probably we are dealing with type 1 diabetes in most of these cases. So you can see their follow-up. You can see their follow-up over next 40 years. This is the graph for survival. You can see significant mortality. If you see these graphs, you can make out that there is a significant mortality every 5 years, those who have developed diabetes before the age of 31. Not only that, if you see these graphs, you see these percentage in terms of blind, impaired vision, MI, CVA, amputations. I think we can clearly make out that point of time significant complications over the year, whether it is microvascular complications or macrovascular complications. Of course, diabetes care has become better over the years. We have got newer insulins, we have got better monitoring devices, we have got newer technology, the education and awareness has become much better. The rates of complications have gone down. Unfortunately, the rates of complication is still high. So I think as pediatrician, as endocrinologist, all of us need to work really more hard, or work better together to further decline these rate of complications, especially for our country. So the DCCT trial, I'm sure, must have been discussed in the previous module. So this is like a trial which forms the basis of modern treatment and its goals for type 1 diabetes. This trial was specifically for type 1 diabetes. It started in year 1983, and the primary aim was to compare intensive and conventional glycemic control. 1,441 persons with type 1 diabetes between the age of 13 to 39 years and diabetes duration between 1 to 5 years, they were included. You can see the baseline parameters. So there were two cohorts. One was the primary prevention cohort when there were no complications at baseline, and in secondary intervention cohort when the complications they were already there at the baseline. Both the intensive and conventional treatment they were compared. You can see the age, mean age between 26 to 27 years, significant number adolescent, male female almost equal, duration of diabetes roughly 2.6 years in the primary prevention cohort and somewhere around 8.5 to 9 years in the secondary intervention cohort. This is about the insulin dose. The baseline HbA1c, you can see between 8.8 to 9.0. So this was the baseline parameters for the DCCT trial when it was started in 1983. So the trial duration was for 10 years. During the 10 years, you can see remarkable benefit in the intensive glycemic control. The mean HbA1c in the intensive arm was to the tune of 7%, while this was somewhere around 8.9 to 9% for conventional glycemic control. So you can see in the intensive glycemic control arm, the risk of eye disease reduced by 63%, risk of kidney disease reduced by 39 to 54%, or risk of nerve damage reduced by 60%. So I think we can see remarkable benefit as far as microvascular complications are considered in the 10 years of DCCT trial. These patients, when the trial ended after 10 years, they were further kept in follow-up. So as of now, we have like 18 years further follow-up, which is actually the post-trial follow-up. Once the trial ended, you can see here, the glycemic control becomes similar in both the arms to the tune of like 8% in both the arms. Of course, in conventional arm also, now there were efforts to make glycemic control better because now we have realized that intensive glycemic control is critically important. So now you can see the HbA1c control remains similar once the trial ended, but the benefits continued. And that's the beauty about early intensive glycemic control. In fact, some of the benefits which could not be seen during the trial period, primarily in macrovascular complications, now those benefits they became remarkable in the further follow-up of participants who had intensive glycemic control during the trial arm, even when they now had similar glycemic control to conventional arm in the follow-up period. Because the macrovascular complications starts late and their benefits may be seen later. So in ADDICT trial, that is the follow-up of DCCT trial between 1994 to 2011, there were persistent benefits for microvascular complications and there were new benefits that were seen for macrovascular complications. To combine DCCT and ADDICT in intensively controlled arm, you can see eye disease reduced by 50%, decreased EGFR reduced by 50%, cardiovascular events reduced by almost to the tune of 60%. So I think the message is very, very clear. Intensive glycemic control decrease the risk of microvascular complications and macrovascular complications in long-term follow-up. We try to achieve HbA1c less than 7 for most participants with type 1, most children with type 1 diabetes. Of course, there can be exception to that I will discuss. So these are in general goals. We generally follow ADA or SPED goals. So you can see HbA1c in general less than 7. The pre-meal blood glucose when they are doing monitoring with the glucometer 70 to 130. Post-meal between 90 to 180 and pre-bed between 80 to 140. So these are in general glycemic goals for children with type 1 diabetes. Now I think the monitoring part is very, very important because in practice, what I have realized that monitoring does not happen. The screening for complications does not happen. Whatever we discuss, in practice, things are actually not translated. You can identify these kids that not even single HbA1c in the last 1 year, and that's true for adults also with type 2 diabetes. So I think you need to just feed in their mind that HbA1c every 3 months. Every time a child with type 1 diabetes, their families are coming to you, you just ensure that HbA1c every 3 months. Getting HbA1c every 3 months can also make a lot of difference. Once you know that yes, HbA1c is high, you will at least do something in terms of monitoring, in terms of adjustment of insulin doses, in terms of the child and the family will also realize that some dietary changes may be required. Some things which when the child was not compliant, the compliance becomes better. So at least monitoring is very, very critical. Regular monitoring with the glucometer, HbA1c every 3 months, and then annual screening for complications is very, very important. So as I was discussing, in general goal is less than 7. However, up to 7.5 is appropriate in the following context, especially children less than 6 years of age who have less ability to recognize hypoglycemia. So inability to articulate symptoms of hypoglycemia, children less than 6 years of age, hypoglycemia unawareness, I think that must have been discussed, or history of severe hypoglycemia requiring assistance of the third person for the recovery from hypoglycemia. Lack of access to analog insulins, lack of access to advanced insulin delivery technology, and ability to regularly check blood glucose and CGMS assess. So I think you can clearly recognize that at least in our country, you will identify so many children and families, unfortunately, who may not be even regularly able to afford for glucometer and strips also. They may be simply on conventional insulins from government dispensaries. The finances may be a big issue. So for these kids, even if you try to achieve H1C up to 7.5, I think that is pretty acceptable. So we have to recognize the limitations in clinical practice, social limitations, financial limitations as well. On the contrary, many of these kids, they may be regularly on CGMS devices. So I'm sure, I think there was one session by Dr. Rajiv Singla and Dr. Deepak about the how to interpret CGMS, how to sort of use CGMS devices in these children. So we have like time in range, time below range, and time above range. Time in range in general, glucose readings between 70 to 180. Below range less than 70. It can be level 1 hypoglycemia less than 70, level 2 hypoglycemia less than 54. Then you can have time above range and level 1 hyperglycemia more than 180, level 2 hyperglycemia more than 250. So in general targets, again it is in general targets, you want at least 70% in range between 70 to 180. Time below range should be less than 5%. Level 1 hypoglycemia less than 4%, level 2 hypoglycemia less than 54, less than 1%. Time above range less than 25%. and level 2 hyperglycemia more than 250 should be less than 5%. So these are in general targets as far as CGMS is considered. Now coming to the reality. So this is again from US data, paper published in 2015 in Diabetes Care. Type 1 Exchange Clinic network currently includes 76 US based pediatric and adult endocrinology practices in 33 states, more than 16,000 participants, age between 2.7 to till more than 90 years of age. Duration of type 1 diabetes between 1.5 to 83 years, 50% were female. So you see here in small kids less than 5 years, the average HbA1c was somewhere around 8.2. As these children grow, as at the age of 15 years, it was worse, mean HbA1c more than 9%. And you see this window between 5 years to 25 years, or 5 years to 20 years, the worst window of poor glycemic control. And once they grow more than 25 years of age, the glycemic control becomes relatively better. And as the age advances, this is of a real world data in terms of mean HbA1c. And you can see at the age of 60, 65, 70, their HbA1c is somewhere between 7 to 7.5. Still, if you are talking about less than 7, you don't see these figures at any of the age. Slightly better in the early age group, maybe one of the reason newly diagnosed diabetes, honeymoon phase, and these are in parental control, very small kids. Once they are into the adolescent phase, it is like a very difficult period for glycemic control that point of time. There are hormonal changes in the kids. There are psychosocial issues. They are not listening to their parents. They are not adherent to lifestyle and in anything. And once they becomes mature, they understand, they accept their type 1 diabetes, then progressively it becomes better. But if you are talking about a ideal goal less than 7, you know, even in a country like USA, still it's a dream. So we have become better over a period of time. And of course, we are not seeing any Indian data here. So if you see the Indian data, I'm sure the mean HbA1c is like 9% for majority of kids with type 1 diabetes, unfortunately. There can be many reasons for that. The poor follow-up can be the reason, not non-compliance can be the follow-up. Regular monitoring may not be happening. HbA1c may not be done at regular intervals. So there can be lots of issues, dealing in, when you are dealing with children with type 1 diabetes. So as I was discussing, the complications screening is very, very important, because if you wait for symptoms to indicate complications, by that time that is actually very late. So when we are talking about HbA1c every 3 months, the annual screening for microvascular complications and macrovascular complications is again very mandatory. And make sure when the child of type 1 diabetes is coming to you, the child should be screened for annual complications. So for nephropathy, so what is important? Generally, less than 10 years of age. And when the diabetes duration is less than 5 years in type 1 diabetes, complications generally have not been reported. And in type 1 diabetes, you are generally sure about the duration of diabetes because the onset is very dramatic. Unfortunately, in type 2 diabetes, sometimes the disease can go undetected for many years. So duration may not be that clear. In type 1 diabetes, when the child is less than 10 years of age and duration of diabetes is less than 5 years, complications are extremely rare. And even if you don't do screening till then, that is adequately okay. And as per the recommendations also, the screening may not be done in children less than 10 years of age and type 1 diabetes duration less than 5 years of age. Once they are more than 11 years of age or diabetes duration is more than 5 years, you have to do annual screening. So for nephropathy, two important tests are urine albumin creatinine ratio and serum creatinine, and you have to calculate each EFR. The risk factors for nephropathy: hyperglycemia, hypertension, dyslipidemia, and smoking. Again, for retinopathy, fundus photographs or ophthalmoscopy by a eye specialist. Again, the risk factors are hyperglycemia, hypertension, lipid abnormalities, and obesity. In neuropathy, I think the most important is clinical examination, history and physical examination. Some basic test. If you have a 10-gram monofilament with you, you can check with that for the touch sensation. If you have got like biothesiometer, like endocrinologist, as we generally have biothesiometer at our clinic, so we can check for the vibration sense. That is the BPT, vibration perception threshold. So these are very basic tests. So for neuropathy, I think the clinical examination is the most important thing. History and physical examination. No laboratory investigations. So again, the risk factors are hyperglycemia, obesity, age, diabetes, duration, and genetics. So one of the most important risk factor for all the complications may not be mentioned here is diabetes duration. So as the duration progresses, the risk of any complications increases. Macrovascular disease, again, you can see here lipid profile every 2 years, annual BP screening. Again, the risk factors are hyperglycemia, hypertension, lipid abnormalities, obesity, and smoking. This is the complications assessment follow-up. So once you have assessed at baseline, so as I was discussing for retinopathy, you have to do annual screening. And the simple is fundus examination. If you have a fundus camera at your clinic, wonderful. Of course, I don't expect the pediatrician to have fundus cameras in their clinic, so you can refer to the eye specialist, specifically writing fundus examination, retina examination to rule out diabetic retinopathy. And if eye specialist is doing it, should be dilated. They need to put sort of mydriatic eye drops and then do dilated fundus examination to see the peripheries also. Of course, if complications happen, then you have to refer to the retina specialist for some laser treatment, anti-VEGF treatment. For neuropathy, again, the most important thing is the clinical examination. And again, annual screening is very, very important. If you have like vibration perception threshold or 10-gram monofilament, again, they are very simple devices. And the treatment is primarily symptomatic. Then coming to nephropathy, again, the annual screening is important. Two important tests are UACR, urinary albumin creatinine ratio. We check in the spot sample, and serum creatinine and calculating EGFR. And this is very, very important. And if unfortunately they have developed nephropathy or proteinuria, the drug of choice is ACE inhibitors or ARBs. For macrovascular complications, again, annually or need-based, at least history and physical examination is important. Check their BP regularly. Check their lipid profile every 2 years. If they're reporting some symptoms, take them seriously. And of course, if they are developing some complications, then drugs like antihypertensives, statins, etc. So for other complications, I think the important thing is low threshold for detection. That is very important. Like for skin disease, for infections, for dental problems, for mental health issues. So, history and physical examination is the most important thing. And keep a low threshold. If a diabetic child is complaining of some urinary symptoms and some flank pain, you must have a low threshold for emphysematous pyelonephritis. If a diabetic child has some dental problems and everything, you must refer to the dentist to rule out dental caries and other issues. So important thing is low threshold for detection, good history, good physical examination, and treatment as needed. So I think if we are talking about preventing complications, then the most important thing is the good glycemic control. And intensive glycemic control, we have clearly seen that it can decrease the risk of complications. We have also talked about other risk factors. So when you want to prevent complications, it's not only intensive glycemic control, it's intensive metabolic control. If they have hypertension, you have to adequate control hypertension. If they have dyslipidemia, you have to correct that. In the initial stage, lifestyle interventions may be okay. They may be candidates for statins also at the earliest, depending on the degree of dyslipidemia and other cardiovascular risk factors. If a type 1 diabetes child or adult is smoking, that is a worst risk factor. Very, very strong, discouraging them to, make sure that they should quit or they should stop smoking. Smoking is one of the very worst risk factor for any micro and macrovascular complications. You can see the higher BMI as one of the risk factors for many complications. Nowadays, with overall increase in the risk of prevalence of obesity, it is not uncommon to see a child with type 1 diabetes as overweight or obese. I have many kids with type 1 diabetes who are either overweight or obese. Then, sort of efforts, dietary efforts, lifestyle efforts, exercises, to control weight becomes equally important. So I think to prevent complications, intensive glycemic control, other than intensive glycemic control, it's primarily intensive metabolic control, adequate control of hypertension, adequate control of dyslipidemia, maintaining their body weight in the ideal body weight range. If they are smoking, that has to be quit. And if they have other risk factors, those need to be addressed. Like, if somebody has developed microalbuminuria or kidney disease, this is itself is a very important risk factor for future microvascular disease or cardiovascular complications. So if you prescribe ACE or ARB, it not only prevent further progression of proteinuria, but it can also decrease the risk of future cardiovascular disease as well. So just to summarize, the intensive treatment, intensive glycemic control towards lowest HbA1c possible without causing severe hypoglycemia. It helps in prevention of long-term complications. So I think that is a very important line, lowest HbA1c possible without causing severe hypoglycemia. That is very, very important. And diabetes complications should be screened as per schedule for early detection and treatment. So just to summarize my talk, I think over the last few modules, we have clearly seen that most of these kids, they roam here and there with poor glycemic control. Unfortunately, they many of them they end up with micro and macrovascular complications. The important thing, the DCCT trial, the follow-up trial has given a very clear indication that intensive glycemic control can delay micro and macrovascular complications. And overall, it's not only glycemic control, it's overall metabolic control. Control of other risk factors is critically important. The complications once happen, it's already too late. If you are waiting for symptoms to happen and then see for complications, it's again too late. Proactive screening for complications is very, very important. And you have to make sure with every type 1 diabetes child and their families that annual screening is very, very important. Unfortunately, in practice, it does not happen. And by the time we recognize that retinopathy is there, the child has already symptoms of floaters or blurring of vision, and it may be already to the late stage of moderate NPDR or severe NPDR or sometimes proliferative diabetic retinopathy. So that stage is already late. Sometimes the vision loss has already happened. So early screening, detecting these complications at an early stage, so that point of time, if you intervene, you can further prevent those progression of complications. You can prevent vision loss. You can prevent progressing to end stage kidney disease. You can prevent child going into stage of dialysis into the adulthood. You can prevent food complications to happen, amputations, gangrene, etc. So proactive annual screening is very, very important. And if you identify any complications, then you have to become more vigilant and then do these tests more frequently. If the child already has microalbuminuria or macroalbuminuria, then your renal functions and urinary albumin creatinine ratio, you might have to check every 3 to 6 months, depending on the degree of renal abnormalities. And that point of time, you might need to decide whether you need to send the child to the nephrologist or to any further specialist. So I think the important message of the today is that in practice, unfortunately, screening does not happen. If as a sort of a well-care pediatrician you happen to encounter, or you have type 1 diabetes children following with you, you make sure their A1C is done every 3 months. Their screening for complications happens on an annual basis. You try to achieve best possible glycemic control. You try to achieve regular monitoring, at home with glucometer and strips. If these kids they can afford, families they can afford, then they can be, on CGMS devices and further use of technology, etc. So I end here, and I thank you again to the IAP team, and special thanks to Dr. Rajiv Singla. Thank you.
Yeah, so I think that was an excellent session there by Dr. Deepak Khandelwal. Yeah, so please write down your questions in the chat box. So while I ask a couple of questions myself from Dr. Deepak. So Dr. Deepak, couple of things that I just want to clear here now that you are here with us is does puberty has anything to do with onset of complications in children with type 1 diabetes? Does it play any role?
I think, Dr. Rajiv, thank you very much. And I think this is important. And puberty has a very important role because of hormonal changes. And in fact, puberty is the time when the complications starts to set in children with type 1 diabetes. That's why we say pre-pubertally, generally the complications does not happen. Sometimes because the exact stage of puberty may not be known, and that's why we generally take as a cutoff of 10 years and diabetes duration less than 5 years. Otherwise, puberty is, sort of one sort of point of time when they become sort of prone for complications, especially when the diabetes duration is now already more than 5 years.
Yeah, absolutely. I think if you would remember, our teacher, Dr. Amini, used to say that we know that till adolescence, it's very difficult to control their glucose values. But once they've hit a puberty, they've already gone into adolescence. And then kind of that's the time we really need to be aggressive about treating their type 1 diabetes. Yeah, so another thing is, I think Dr. Tandon briefly touched about this topic in very first session, that somebody with type 2 diabetes, youth onset type 2 diabetes, like if somebody develops type 2 diabetes at say 20 years of age, now that we see those people very, very commonly in our practice. So do they tend to have more complications than children actually with type 1 diabetes who may be living even longer with type diabetes than them?
Yes, I think again it's very important. In fact, the YDR registry data I have seen, the two-day study data we all have seen. In fact, the complications are much more in type 2 diabetes. On the contrary, in the screening part, in fact, may be relatively better in type 1 diabetes as compared to type 2 diabetes. Type 2 diabetes is actually much more ignored as compared to type 1 diabetes. Many times the diagnosis may be delayed for many months to years also. It may be asymptomatic as well. So many of these younger persons, they may already have complications at the time of diagnosis as well. And overall, if you see there, 5 years duration or 10 years duration data for type 1 versus type 2, the complications are more remarkable, especially for macrovascular complications in type 2 diabetes as compared to type 1 diabetes.
Right. Yeah, so we've got a comment/question in our chat box here. Is the window period of almost 20 year in real world data shown where HbA1c was around 10? What are the chances these kids develop microvascular complications even if HbA1c was relatively better at later age?
So difficult to comment, but yes, if they have already spent initial 20 years in a poor glycemic control,
Yes,
then there are very high chances that they are likely to develop some degree of microvascular and complications.
yeah, absolutely. I think I also remember from one of the talks that I did at ASICON last year was that the life expectancy in any case for children with type 1 diabetes, especially in India, is very kind of low. It is almost to full potential in Scandinavian countries where type 1 diabetes is really prevalent. But in India, actually the studies show, and we of course we know that the data may not be as complete as it is, but they say that life expectancy with type 1 diabetes is almost around only 50 years or so in India. So of course that tells us that if the diabetes is not very well controlled in initial part, then the chances of complications and even mortality is very, very high. But of course, we also need to understand is that whatever data is coming from is from an olden, from the old era. Now the way we are practicing with nobody who's kind of seeing this lecture or listening to this is should take a message back home that it's a useless cause. Of course, because the way we're treating these children now has entirely changed, and we do hope that doing all these efforts and with better resource availability, the life expectancy is going to increase much more. And US and UK and in most of the Europe, the life expectancy is as good as in people without type 1 diabetes there. Yeah, so I think those were the only questions that we had. I think we had an excellent session here. Thank you so much, Dr. Deepak, for taking out.
Any specific comments from your side, Dr. Rajiv?
No, I feel that, see, generally, I believe that it is very, very common in my practice, at least with type 1 diabetes, to see people coming with retinopathy and nephropathy at 40 years of age, at 45 years of age, and few people even at 35 years of age, which actually reflects poor glycemic control uh, uh, spanning over long time. So I think we need to be aware about it. And of course, we need to continuously strive towards better glycemic control in children. I think from the past times, as we've covered in older sessions also, I think we now very, very uncommonly see people who are on premix or less than 4 injections a day. So I think we see much more awareness in schools. People know how to check their sugars. It's generally an acceptable thing for taking care of children, apart from exception of 1 or 2 schools here and there. So generally, I believe that the atmosphere towards care for children in general is increasing. So I hope to see that the complications that we've seen in past, we will have much more positive outcomes in the coming days.
Absolutely agree. I think all very pertinent comments.
Yeah, so I think with that we close this session today, and very, very happy Holi to all of you. Thank you, Dr. Deepak, for taking out time out of your vacations to be with us here today. Thank you so much. We have only few sessions left. I think a couple of more interesting sessions coming next week and next to next week. So see you all next week. Thank you so
Thank
much.
you. Thank